and will be here in any minute to be able to finish the lecture. But we have a very generous offer from Jackie to start it so that we don't delay anybody. It's Dr. Haney's information, it's her slide deck, so I don't want anyone to feel like they're getting robbed of the experience. And as soon as she finishes saving a life, she will be here. So I'm going to say a couple of things about her, and then that way she won't get robbed of that as well when she does get here. So Dr. Haney is a board-certified surgeon who specializes in the treatment of benign and malignant breast disease. Dr. Haney only does breast, so she's dedicated to the field of breast surgery. She did her training at John Wayne down in Huntington. And Dr. Haney is probably the most passionate person I know about caring for patients. She does the right thing every time, and she goes above and beyond. And I cannot, if she were here, she'd be blushing in the corner and tell me to stop. So I'm taking this opportunity to say some really nice things about her. Dr. Haney sees all kinds of patients. So she sees patients who have cysts. She sees patients who are just having breast pain or breast abnormalities. So it's not specific just to cancer. And in her talk today, she's going to talk about how to prevent breast cancer, how to know your body, how to be able to be your own best advocate. So to start, I want to introduce Jackie. Jackie is one of our nurses in the breast center. She is an oncology certified nurse for 17 days. Oh, 18 days. She has been a nurse for 31 years. I knew that off the top of my head. And she's one of my dearest friends. And Jackie is really a great patient advocate. She's going to talk to you about a project that they're participating in over in the breast center called Knitted Knockers. And when she says it with her accent, it'll sound much more proper. So without any more ado, I'll introduce Jackie. And like I said, Jackie will start the presentation, and Dr. Haney should be here as soon as she can.
So as Jenny said, we have a project going on in the breast centre that I started just this summer, and it's called Knitted Knockers. And the idea is for people who know how to knit, and I've been knitting since I was 7, so when one of my patients said to me, "Have you ever heard of knitted knockers?" I said, "No." And so she put me onto what they were, so I took a look at the website and found that a lady had designed a pattern to make a breast prosthetic. And they can be made in cup sizes A through E, and they're made with nice soft cotton wool that will go, feel nice against the lady's skin after a mastectomy, and filled with hypoallergenic stuffing. So I try to find where these are made so that I can get some supply for our patients, only to find that there isn't anywhere in Kern County that makes them. There isn't any ladies actively making knitted knockers. So I thought, okay, well I knit, so I'll start making them. Well, I know I can't meet the demand for all the ladies who need them, so I approached the knitting guild in town called What the Knit, and joined the guild, and there's over 100 ladies in this guild who were delighted to help me move forward with the project. So since the summer, we've had 60 knockers knitted, and I've given out, I think it's 25 at my last count. And so ladies can wear these as early as 4 weeks after surgery, whereas with the breast prosthetics that you get, the gel ones, they have to wait longer to wear those. They really need to be fully healed, and they can be heavy and cause patients to sweat a little bit. Whereas with these, they're very lightweight, not heavy at all, and they're very comfy against the skin, and they can just pop them into the bra and go on about their day. The patients are loving them because when somebody hugs them, you can't feel anything other than nice soft breasts like people would feel anyway. So I just wanted to share with you what we're doing, because we're always looking for more knitters, and not only more knitters, patients who need them. It's not restricted to patients who are our patients in the breast centre. It's for any lady in Kern County who has lost a breast, who needs a prosthetic. They can give me a call and tell me what size they need. I have a knocker cupboard, and I'm trying to build up the stock. And so I'll go to the knocker cupboard and see what I've got, and then they can come in and collect them. They're completely free for patients. They don't have to pay anything. I always take donations of yarn, fill, money, or to buy yarn and fill. If anybody wants to donate, that's no problem either. But otherwise, the local guild has donated yarn, and as I said, I knitted them for me. So we have ladies stop by the centre all the time now. I've got some knockers I've knitted for you, and they drop them off for us. So I'm going to pass this little basket around so you can see what they feel like. And if you know anybody who needs a knocker, just have them give me a call at the breast centre, and I'm more than happy to hook them up with some new girls. So they can wear them swimming, they can be washed, and so they're really very versatile and great. Absolutely, yeah, that's actually about what the guild, but I've got some patterns in brochures if you want one of those too.
That's all she does is knit blankets and all kinds of stuff, so this might be something.
Oh yeah, apparently the ladies told me they got sick of knitting baby hats and blankets, so knockers are quite the novelty for them. So, and it brings quite a laugh when I say to people, I'm just going to take the time to show you my knockers. There's a patterns inside there. So, I've had so many people say, well, does knockers mean the same thing in England as it does here? Yeah. So, any questions about knitted knockers?
You said you could wear them swimming. Don't they hold the water and get heavy on you and want to...
They do, but they use acrylic yarn when we do them for swimming so that they don't hold as much water. But because you can wash them, they just air dry. We don't put them in a dryer or anything afterwards. You can, as long as the swimsuit will hold them in, we can wear them swimming with no problem. Patients report that they really do work quite well. Some people put a little stone in them to just keep them. They want them a little bit heavier, so they'll put a little stone in if they feel like that. Some patients don't need it, you know. And most of the colours that we have are natural, but some of the colours are bright, you know, rainbow colours, and some people like those too. So it really doesn't matter if people have leftover yarn. If it's the right kind of yarn, they can be knit in multicolours, plain colours. It doesn't matter. So. Okay, so I'll start a little bit on Dr. Haney's presentation, and hopefully she'll be here in a moment. So, what she wants you to get from this education is, first of all, that all ladies should be an advocate for your own health care. That's you ladies in the room, and then for you to advocate to your friends and family, for them to be advocates for their own health care. If you don't speak up about an issue that you have, then the doctors and the nurses aren't going to know that you have it to actually do anything about it. So for the ladies who are over 40 or ladies who know they have risk factors, you should get a mammogram once a year, starting at age 40, earlier if you have risk factors. If you do find a lump in your breast, the key is not to ignore it, thinking it's going to go. Sometimes lumps you'll find they will be gone the following week, and then some lumps do come and go, but if you're doing regular breast exams, you'll know which lump is always there around the time of your period and which one isn't. But if you get a lump that's there, have it checked out. We would much rather you be told it's something that's benign than have you not get it checked out and then come and see us 6 months later and now it's a huge breast cancer. Be aware of your family history, and that's not just the family history, and I'll talk more about this as we move through, not just your family history of your mom, but family history from dad's side too, because men do get breast cancer, and if he has, your dad has sisters that have breast cancer, that's also your family history. So you need to know your own family history, who had which type of breast cancer, or any cancers, and what age they were when they were diagnosed, because that makes a difference to your own personal risk too. Identify risk factors that you can change to lower your risk of getting breast cancer, and I'll talk more about what those are. And remember, this doesn't matter whether you're talking about your breasts or anything else in your body, you need to ask doctors questions. They don't know what you're thinking magically, and they're not some sort of gods. I'm going to say that while there's no doctors in the room. They're not some sort of gods that just tell you what you need to have done. They need you to tell them what things are going on with you and ask questions. It should be an open dialogue between you and your doctor. You should be comfortable with your doctor to be able to tell them anything, and comfortable enough to be able to ask them anything. And if you're not, find yourself a doctor that you are comfortable with, because that's key. So statistics. 1 in 8 women will get breast cancer during their lifetime, and that's 12% of the female population in the US. In 2016, it's estimated that there'll be almost 250,000 cases of invasive breast cancer, 61,000 cases of ductal carcinoma in situ, cancer that's in place, that hasn't invaded anywhere yet, And just over 40,000 women this year will die from breast cancer. That's just 2016. We have almost 3 million breast cancer survivors in the US currently. The good news on this is that the rate of breast cancers being discovered is less than the rate of people dying. You know, the people dying, people are living longer, so they're dying at a slower rate than they're being discovered. So each year we're having more and more and more breast cancer survivors because people are living longer and doing better. We're finding breast cancers earlier, which is better for the patient. Men can develop breast cancer, but at a much, much lower rate than women. It's just less than 1% of the general population of men that will develop breast cancer. But they still can. I lose count of the amount of times we're at health fairs and we have our fake breasts to try and teach women how to do breast exams. And we ask the men to come and learn how to do a breast exam, and we ask the men to feel the breasts. Can you find them? And how many men are like, oh no, I don't want to touch that. Oh really? Have you never touched a breast before? Yeah, but they don't think about it in relation to themselves. But it's really important for men to also know to check their own breasts too. So what are the risk factors? First of all, with the exception of 2 gentlemen in here, we all have one of the main risk factors, and that's being a woman. It's 100 times more common in us than it is in men. Most breast cancer patients are postmenopausal. 1 in 8 invasive cancers occur in ladies under the age of 45, but 2 out of 3 invasive cancers are in ladies over the age of 55. So it is much more common in the older woman, but we do see a lot in younger ladies. We have a lot of younger ladies. And if you've all picked up the magazine, you'll see the lady on the front cover of the magazine is 23 years old. So it does happen in younger ladies, for sure. If you have a personal history of breast cancer, you've already had breast cancer, say, I don't know, 10 years ago, then that increases your risk of a new breast cancer in the other breast 3 to 4-fold. And a new breast cancer is different from the breast cancer reoccurring. If it's a reoccurrence of the one you already had, that's different from being a brand new one in the other breast. Breast cell changes, and this is where the benign breast disease that Jenny mentioned, Dr. Henney also takes care of. Sometimes on mammogram they see something that's not quite right and they send you for a diagnostic mammogram, and then they send you for an ultrasound and a biopsy. And it comes back as atypical ductal hyperplasia or atypical lobular hyperplasia. And the atypical ductal hyperplasia often is a precursor to breast cancer, and that can develop into breast cancer. And so usually that's taken out because we don't want to leave it in there and give it the chance to turn into breast cancer and then treat it once you've got cancer. We take it out beforehand. The atypical lobular hyperplasia, the same thing. If the changes are starting to happen, we want to get it out before it actually becomes ductal carcinoma. And this can only be diagnosed by a biopsy too. It raises your risk 4 to 5 times that of the general population without having atypia. So it's really important to get those mammograms to diagnose that too, because that can be diagnosed on mammogram with a following up with a biopsy. Lobular carcinoma in situ also raises the risk 7 to 11 times for invasive carcinoma, and ductal carcinoma in situ also. I think there's another slide on that, I think. Yeah, I'll talk about that in a moment. This drug that I can't pronounce, DES, and if I did pronounce it, I'd pronounce it the English way anyway. So, that was a drug that was given to women between the years of 1940 and 1971 to help avoid miscarriage. Some of you may have heard of it. And that is also known to be an increased risk of getting breast cancer. So often when the doctor's taking the medical history, she'll ask if you have any history of taking that if you are an older woman. If people have particularly leukemia or a Hodgkin's lymphoma, and as a younger woman or as a child, and they have to do radiation to the chest, because of the radiation, that increases your chance of getting breast cancer as an adult. Breast density. Do you all know, those of you who've had mammograms, do you all know whether your breasts are dense or not? Have you looked at the report to find out? Yeah? You know? Because you should know. Not all states in the country have to tell you. And it's fairly new that we have to be told. 25 states currently in the United States have to report on your mammogram report what the density of your breasts are, and California is one of them. The density is, it just means that's how much breast tissue basically is in your breast. And that density, if your breasts are category 3 or 4 and they're fairly dense, the mammogram can't always see all of the tissue. 3D mammograms have helped, but it doesn't completely erase the fact that dense breasts will still hide things that we want to see. After menopause, often the breasts become less dense and they become more fatty, but you still can have density after menopause too. So mammograms can't always see. So if breasts are very dense, the doctor will often order an ultrasound as well because of the dense breast to see if we can see things that the mammogram does not see. California had been one of the 25 states that has to report dense breasts. Also now the insurances, because originally, of course, when you're doing ultrasounds for density, then they'd say, oh no, we're not going to cover that. But the laws have changed to allow that to be covered too if there is a history of dense breasts. So density is determined by how old you are. Usually the younger you are, the more dense the breasts are. The menopausal status, as I said, they get less dense after menopause. And if you've taken hormone replacement therapy and your own genetics, you'll make up your genes. I keep trying to put the slide forward with the microphone. That doesn't work. If you have a family history of breast cancer, and your first-degree relatives, such as your mom, your sister, and daughters, that will double your risk of getting breast cancer. So it's really important to know what that family history is. If you have 2 first-degree relatives, and that's the mom, sisters, daughters, that increases your risk by 3-fold of getting breast cancer. Your extended family, your aunts and first cousins can also play a part in genetics. If you have a lot of extended family that have breast cancer, that can also indicate there may be a higher risk for you. But it is important to understand that most breast cancers are not anything to do with genetics and family history. Only 5 to 10% of all breast cancers are genetically related. So that means overwhelmingly most breast cancers we see just happen just because, not because of any family history or any genetic mutation or gene that you may have. So 5 to 10%, like I said, of breast cancers have a genetic mutation, and the one that they mainly talk about is the BRCA1 and the BRCA2. And this was made famous a few years ago with the actress Angelina Jolie, when she was found to be positive for the genes and had double mastectomy and her ovaries removed as well. So testing is available for the mutations. We have a genetics counsellor at the breast centre, a nurse called Julie, who specialises in genetics. And if you have a family history, or depending on your age, when you present with breast cancer, Dr. Haney will refer you to see Julie to go over all of your family history. Now for Julie, she's going to ask you detailed questions about the family. It's not good enough for her to have this vague notion of, oh yeah, I think mom was maybe 45, or maybe she was 51, or that doesn't work. She wants to know real detailed stuff. So she wants to know the age of the family member when they got the cancer, if they're still alive or not, and if they died, the age when they died. Anything that you can gather to take to Julie for, 5 minutes?
She said that I had to pay for her speeding ticket on her way here.
So Julie will go over all the family history with the patients and then test the patient. If, for instance, your mom had breast cancer and she was tested and she was genetically negative, usually you don't need to then worry about it, because she can't pass on a gene that she didn't have. So we don't have to test everybody when somebody shows up. We'll just test one person, usually the person with breast cancer first. And if she's positive, then yeah, we'll go on and test other people. You don't usually have to worry about it until the testing is done in the one person.
What about a mother and a grandmother maternal?
Oh, yeah, then your mom would get tested, and
They're
then,
both passed.
then you would.
And then they refused to do it for me.
Oh, but then you
So
can get
I'm
it.
just going to come see you guys.
You can do it. It depends on how old they were though when they got breast cancer. It depends.
59 and grandma was in her late 50s.
Because if they're over 50, you don't always need it. So it depends on your personal risk, genetic risk, and family history. It's never an easy answer, unfortunately, with genetics. So, but patients with the gene mutation do have an increased chance of getting breast cancer in their lifetime. So we often will wait if the person's under the age of 40 and they have no family history, for instance, or even if they do, and we want to get genetic testing, we'll often wait for those results to come back before we actually proceed with surgery. Because if that result is positive, then Dr. Haney will talk to the patient about double mastectomy. Do you want to take off both breasts because you have the gene? And if we just took you to surgery to get the cancer out, and then you find out you're positive for the gene, then you've got to go back for another surgery. We don't like to do that. Surgeries are not, and I mean, a lot of people just think surgeries are they're just easy. Just knock me out, do the surgery. But getting general anaesthetic is a big deal. And they're inherently dangerous, and there's a lot of safeties in the OR, and that's why we don't have more problems. But if you don't have to go into surgery twice, you don't want to have to. There's a higher incidence of additional cancers as well, such as ovarian cancer, pancreatic and prostate cancers, if people test positive for BRCA and for various different variants. I'm not telling a lie here, but we must learn about new variants that are coming out almost every month. We don't necessarily know what they all mean, but they'll say you've got the strange names, you know, you've got the BYA variant and you've got the XYZ variant, but we don't know what the clinical significance is yet. So the companies who do this genetic testing keep records of all these different variants in the hope that when we find enough of them, we'll be able to learn more about them to know what does that mean to people down the road. Now here's the personal things we can do. This is the part that I should probably have Dr. Haney do so she can get pummeled with rotten tomatoes and not me. But this is what we personally can do to reduce our risk of breast cancer. And pretty much all cancers and heart disease and everything else. If you're overweight or obese after menopause, but really before menopause too, that's a risk factor. And one of the main reasons for that is that fat cells carry a small amount of estrogen. So just because you've gone through menopause and you're not producing your own estrogen anymore, the fat cells do contain some. And we know we produce a little bit of estrogen after menopause, but some of that is in the fat cells. So that obviously the more fat cells that you have, the more estrogen you have. And if you have a breast cancer, most breast cancers are estrogen receptive, which means estrogen feeds them. So obviously the more fat that you have, the more estrogen you've got that feeds that breast cancer to make it grow. So the more that we can do to stay within our own, the correct weight for our height and build, the better off you'll be because you have less fat to give you those extra estrogen. So a lack of physical activity, of course, usually goes along with being overweight, right? If we're not very physically active, we tend to be a little bit more overweight. The Women's Health Initiative found that just 1.5 to 2.5 hours a week of brisk walking reduces your risk of breast cancer by helping to reduce your weight by 18%. So that's a good incentive to get out there and walk. And drinking alcohol, 2 to 5 drinks a day can increase your risk 1 to 1.5 times compared to those people who do not drink any alcohol. So the recommendation is to limit the amount of alcohol to 1 drink a day. And they all tie in. 2 to 5 drinks a day is going to pack on the weight too. So, you know, but that doesn't mean to say that you can walk an extra few miles and then drop the fat and drink more. It doesn't work. I know. I always, that's how I try to rationalize it, but it never works. So you need to reduce all of it, reduce the weight, increase the physical exercise and reduce the alcohol, and that will help. And not that, as I said, you know, I'm sure I'm preaching to the choir, you know that's not just breast cancer, that's your heart as well, and everything else that we've got going on. It helps with everything. So, what are the symptoms of breast cancer? Sometimes there's none. Sometimes you go for your annual mammogram thinking, well, everything's the same, my self-breast exams are the same, I don't have to worry about it, and you don't feel any pain, nothing, and then the mammogram comes up with something, you have a biopsy and it's positive for breast cancer. So sometimes there's no signs or symptoms, but if you find a lump or a mass in the breast, If it's like a hard little frozen pea, it doesn't change. If you still have your periods, or it still have, you know, the hormones are still cycling, and that lump doesn't change, that's a sign that you need to have that tested. It goes back to what I said in the beginning, don't ignore that lump. If you have swollen lymph nodes, particularly under your arms, that's another sign that you should have something checked out. You know, I know this time of the year we're going into flu season, we all get swollen glands in our neck, but that's not where I'm talking about. I'm talking about right under your arms. So that's when we talk about doing a breast exam, that we talk about feeling under your arm as well as your breast. If you start to see changes in the skin, suddenly you see a dimple in the breast, or suddenly your breast looks like the skin of an orange, or it begins to look a bit thicker, or there's a red spot on it for no apparent reason, you haven't bumped into anything, you haven't done anything yet, you know, that's another cause for concern. If your nipple suddenly starts to retract, so it starts to go inwards, sometimes a breast cancer can be behind the nipple and it will pull the nipple back. So if the nipple starts to retract, again, it's another reason to go and see your doctor. If you have discharge from the nipples, particularly if that discharge is bright red blood, or it's a brown colour, which kind of like when blood gets old or dries, if it's a brown or a red colour, that you need to see the doctor as well. And that's why when patients call us and we ask, they say, I've got nipple discharge. And sometimes it's just milk, because sometimes our body just, for whatever reason, decides to produce milk, bizarre as that may be, but sometimes that's all it is. So we'll always ask patients, well, what colour is the nipple discharge? If it's a white or yellow, it's not so concerning. We'll still get them in to see us, but it's not as concerning. We'll get them in to see us this week if it's bloody, because that we do worry about a little bit more. And if the nipple begins to get thicker, the same as if the skin on the breast, if the nipple begins to get thicker or red or has some scaliness to it, again, it's another sign to go and see your doctor. So, the self-breast exam. This is something ladies should do every month. If you're going through, if you still get your periods, you should do it about 7 to 10 days after your period. If you don't have periods anymore, then pick a day of the month and do it that day every month, at the first of the month, whatever day. So what ladies should do first, and I'm going to ask you all to stand up and stretch for me. Everybody stand up. What you should do first, sometimes before you get in the shower, and when you're naked, you want to look at yourself in the mirror. Okay, and then you want to raise your hands high above your head. Everybody raise their hands. And you look at your breasts when your hands are raised high. Then put your arms out to the side and take a look at your breast again. Has anything changed? Do you notice a dimple? And then put your hands on your hips and look at your breast again. Has anything changed? Does the shape change? Then hunch your shoulders forward. That's it. And then look at them again. And has anything changed? So that's what you want to do once a month before you start touching your breast. Just do arms up, out to the side, on the waist, and hunch. Okay? You can all sit down now. That's your lunchtime stretch. We had a lady right now that when she was just sitting down on the exam table, that the breasts were the same. When she put her arm up, one of the breasts had a dimple right on the side, and that was the breast cancer pulling it in. But you couldn't see it when she was just sat on the exam table. You could only see it when she put her arms up. So that's why it's important to do that. You're the people who know your breasts the best, except maybe for your husband sometimes, but you're the people who know your breasts the best and what they look like. And it's important for you to look at them every month and to do those different movements. Then, either when you're lying down or in the shower, a lot of people like to do it in the shower because you're wet and it's easier to do it then when your hands are wet and your skin's wet. You want to start up here, like I was saying, in the armpit. That's where you're feeling for those lymph nodes that may be there. You use your three fingers. It's like the Girl Scout sign, if any of you were Girl Scouts. But use the pads of your 3 fingers, and then you start up at the top and go down, kind of like a lawnmower, up and down, up and down. You really don't want to lift your fingers off the breast, because if you're doing this, you're going to miss spots. So you want to use your 3 fingers, and then you do a little circle on the skin, a light circle at first, then a little deeper, and then deep enough to get as far as you can go on the breast. And you do those 3 little circles, and then move your hand down a little bit without lifting your fingers off your skin, and then do the next 3 circles. So you're going to go up and down each breast, and you're going to go right from under the armpit, up and down each breast until you reach the center, and then go to the other side and do exactly the same thing. And if you do that every month, you're going to know how your own breasts feel. And you're going to notice then if something is new that you didn't notice before. Now, sometimes people's husbands or boyfriends find the lump. And it's important for them to know that if they do feel a lump in the breast, that they tell you. So that they, that they don't just think, oh, Jackie has a lump there, but that wasn't there last week. I won't worry with it. It'll probably be gone next time I feel a breast. They need to tell you, because with the amount of times that people come in and say, yeah, my husband found a lump. So it's important. So that's how to do a monthly breast exam. I'm sorry, I got a cold. The next thing is to do mammograms, which we currently recommend. Our recommendations, we follow the National Comprehensive Cancer Network, which is to start the yearly mammograms at age 40. Now, if you have a different risk factor for personal family history and genetics, then it starts younger, but that's so different for everybody that has to be worked out with you and the physician. A yearly mammogram should start when you're age 40. Many women tell me that they don't want to do it because it hurts. And I don't find it too painful. It's a little uncomfortable, but it's not painful. But that little uncomfortableness or that pain that you feel for that 20 seconds is far better than finding out you have breast cancer when it's too late. Yeah. So a yearly mammogram, and that's still the gold standard. Even though a mammogram may not detect everything in a dense breast, a mammogram by far is still the gold standard. 3D mammograms now do find 41% more breast cancers than the old 2D. And I know we have 4 3D mammograms with us, with Quest, in both Quest locations. And Dignity is getting some, and I think CBCC has some. So 3D mammograms are more the norm now, as are 3D stereotactic biopsies. So the Quest has a 3D stereotactic biopsy that sort of keeps your breast completely still, and they have a 3D image to actually hit that biopsy exactly where they want to hit it. And along with the mammogram, if you have dense breasts, as I mentioned before, you will have an ultrasound, so they can look and see if there's anything that the mammogram did not find. Now, sometimes we'll get the patients will come in, they've had a screening mammogram, and then they were called back to have a diagnostic mammogram. And the only difference between the two is with the diagnostic mammogram, they do a few more images, and the radiologist is actually reading it while you're there in the imaging center. With a screening mammogram, they can save them till later and then batch read them later and see if you need to come back. But when we request a diagnostic, it's the same test, but the doctor's right there looking at it as you're having it done. And I know Dr. Dansby here will often talk to the patient before they even leave the imaging centre to let them know what she's seen. Sometimes though, people will come in and they've had a mammogram, they've had ultrasounds, they've had a biopsy, but they do have dense breasts, and so we'll order an MRI, just to make sure there isn't something else lurking. Again, this whole thing of we don't want to take you to surgery twice, we want to get in and do the right thing first time. So Dr. Haney will sometimes order an MRI before surgery to make sure there isn't anything that we're not already seeing. And also for patients who are young and at high risk, if your own family, your own personal risk, yay, come on in. Mammograms are recommended on a yearly basis for some patients. No, here she is. No, you better come up here.
You're doing a great job.
It's too intimidating to do it with you in the room. The ladies want to hear you, they don't want to hear me.
I don't know, but you've already done the presentation.
No, I'm only on screening.
You did all the rest.
But you can go up, Rick.
I'm really sorry, everybody. I don't need this either, do I?
We're saving lives.
Thanks everybody for coming. Sorry. Surgery sometimes takes longer. Okay. So I think she went through everything else before.
So tell me if this is redundant or not. So mammograms are the one test that have been proven to save lives. It doesn't matter who tells you what or who you're going to listen to, they're wrong. Once a year mammogram. Ultrasounds are an adjunctive test. You don't need to do them once a year. MRIs also is a good option for some patients, and obviously biopsy. That's good. Okay, so mammograms are x-rays of the breast. Most everybody knows what a mammogram is. There's two different kinds. There's a screening mammogram, and that's done once a year as a standard mammogram. Diagnostic mammograms are different though. Just be aware that they're picking over a concerning area from an exam or from a change on a screening mammogram. They're going to look for a lump, thickening, change in shape or size of the breast, and they will focus on one particular area usually. And there's more than one picture, and they're read with the radiologist who's in the room. Those are some examples of mammograms. You get squished from the top, and you get squished from the side. So this is the right, this is the left. And what they're looking for is any mass, architectural distortion, or microcalcification. So in this patient, that's for cancer. Ultrasound is just like as if, for anybody who's had kids, the same thing. Uses sound waves to create a picture, and it can tell you a little bit more about the personality of a lump. It can tell you if it's solid or cystic, meaning fluid-filled, the size, and blood flow component. So this is a tumor here. You can see that it's kind of got these little irregular edges with these little finger-like extensions. It's what's called density, so the ultrasound can't see through it. So that's a little cancer. And finally, MRIs. MRIs are great tools. They're generally not recommended for the general screening population because it's they're about 40 minutes. You have to have IV dye, so screening the whole entirety of the population will be difficult using this mechanism. But it's good for certain patients. And the reason is it uses a magnet to create the 3D pictures of the breast, but it couples then the blood flow enhancement. So just to see here at the top, so this is the right breast, and you can obviously see there's the nipple at the top, this is the heart, and the rest of the structures down here. And what you're getting is like a 3D effect, and you can see even the vessels that are coming through, but then here's this big oomball, which is the cancer. In the same picture, in a similar patient, kind of from the right side, they have this mass, and then you can see the blood flow. I like to say it's like the weather map, the Doppler that they show you. So that tells you where the eye of the storm is compared to the remainder of the breast, which is quiet. So it's extremely sensitive, and it can find little cancers that are missed on screening. And MRIs are, again, not generally recommended for the general population, but if for any reason a patient has a lifetime risk of 20%, or has a genetic predisposition, kind of those Angelina Jolie stories, or has a prior history of chest wall radiation, they would benefit from a screening mammogram. In those patients who had breast cancer, we call it a diagnostic study. And so you can see this is a patient who had one side, and then actually the second side was found by the cancer. And you can also biopsy off of MRI, which is really important. So basically, I know Jackie did this, but this is my little spiel. You have to be an advocate for your own health care. Because you see a doctor once a year, and the rest of the time it's on you. So the other 11 months of the year, it's on you. So whenever somebody feels a lump, a bump, a skin change, nipple discharge, nipple retraction, you have to come in and see your physician. Mammograms once a year. And I don't care who's told you what, once a year. Okay. Don't ignore a lump thinking it will go away. It won't. Patients tell me all the time, I wished it, I prayed it, I wanted it to go away. It's not going to. So come in, it's only going to get worse. Be aware of your family history. This is really important, especially in the days where we didn't talk about what grandma had. We didn't talk about anything that happened below the waist or above the waist, frankly. So, it's important to ask questions as much as you can, and it may change where you are. Not only if you're a candidate for genetic testing, which is only about less than 10% of all breast cancer cases are genetic, but it's also how you calculate your own personal risk. So your family history will actually change even your personal risk, even if you're not high risk by genetics. Identify factors that you can change to lower your risk of breast cancer. That's that wonderful slide I'm sure Jackie showed you, which I'm glad she did that I didn't have to do.
I said I wish you were back so you could have the rubber baby credit, you know what I mean?
Yeah, that's my least favorite slide in the entire presentation. Weight loss. Look, I really like to eat. I'm going to eat after this. I like to eat, but it's not necessarily good for me. So, but you have to be, a good weight does a lot of things. It's important not only for breast cancer, but other kinds of cancer. You know, exercise, again, there's nothing better than coming home and taking your shoes off and, you know, laying down on the couch. Every hour you do that, you increase your risk of breast cancer compared to decreasing it. So get up and move. The drinking, I think that goes without saying. And then remember to always ask your doctor questions. So thanks again for your time. I'm really sorry that I was late, so I apologize for that. But if anybody has questions, they can ask. I know Jackie did a good job, so nobody has questions. So.
She did a good job.
Sorry.
And we loved her accent.
Yeah, she's the only one who can get away with saying knockers.
Can you explain that, you know, how the three different risks, the personal, family, and genetic, how all that goes together?
Sure. So when patients, as some of you know, that, you know, people come in to see me, we look at risk. So all of these things that she kind of went through at the beginning, most of them are kind of all kind of tied together. So there are variations of risk models. If any of you wanted to go online, you could go. I think the San Joaquin website used to have a risk model. Susan G. Komen has one. You can do the one that's at the National Cancer Institute. If you have a history of breast cancer, you can't use that. But you know, if you wanted to say like your sister or your mom or one of your family members or coworkers, you know, what's my risk? You can actually go online for free and you can plug your numbers in. So again, for some people it'll sound redundant, but you know, we look at your personal, your family, and your genetic risk. So genetic risk trumps everything else, like Angelina Jolie. So if you harbor a BRCA mutation or one of the other types of genes, you're going to run anywhere between 20 to like 60% lifetime risk. So obviously that trumps everything and anything that you have. So some people are high risk because they're genetically positive. There are patients who have an extensive family history, but you go and test them and they're genetically negative. I like to more term them gene unknown because there has to be something going on. I think of them more as a familial risk. And then there's your personal risk, and that's the model I was talking about. So somebody may come in and they may only have like a mom who has breast cancer, so not an extensive family history, but there's a few other things in those risk models. So they're going to ask you your age. Don't lie when you put it in. Put your age in. It tells you when you started your period, when you had your first child for most of them, and then it's going to ask you a series of questions like your family history. So mom, siblings, and children, and most of the general population ones, we're going to look for first-degree family history. If you were to see a genetic counselor, they're going to look at your aunts, cousins, and do more, and there's additional models that are available to look at extended risk. It's going to ask you if you've had a biopsy. So atypical ductal or atypical lobular hyperplasia, like on a breast biopsy, raises a person's risk 4 to 5 times that of the general population. So when you plug those numbers in, it's going to ask you to pick a background as well for most of them. Then they're going to spit out a number. And the number is going to be, especially if you use the NCI one, the National Cancer Institute model, it's going to look at your lifetime risk, your 5-year risk of invasive breast cancer, and your lifetime risk of invasive breast cancer relative to the average person your age. So it's going to give you a sense of if you're high risk or not high risk. So again, somebody may come in and see me and they have only a mom who had breast cancer, so not genetic, not really extensive family history, but let's say they came in with atypia as well. Their risk is going to be above 20%, and that's going to change how we treat that patient. So it's important that you look at all factors, not just one. And again, depending on if you go through additional extensive models, there's also height, weight, hormone use, all that stuff's going to go into play in your extended family history. So, any other questions? Alrighty, was lunch good?
Yep.
Ooh, score. Again, thanks everybody. I'm really sorry I was late. So. Yeah.